Hello, the time is now 12:30 p.m. Eastern, the official start time for today's broadcast. The topic today is integrating behavioral health into primary care, focus on depression screening. And now, without further ado, I'd like to turn things over to your host, Stacey Hall, Behavioral Health Task Lead for Reliant Quality. Stacey, the floor is yours.
Thank you. Good afternoon, everyone. I would like to thank you for participating in Reliant Quality's Learning in Action Network event today and for your continued commitment to integrate behavioral health into your practices. Before we get started, I want to remind you that in addition to the free monthly webinars, Align is also available to provide free technical assistance to you and your staff. We can assist with things such as process flow, resource coordination, and evidence-based tools. I invite you to take advantage of these services and to reach out to us if you have any questions or concerns. At this point, I would like to turn your attention to the depression screening code. These are important codes that can be used in your practices. And now, it is my honor to introduce Dr. Edwin Boudreau. Dr. Boudreau is a clinical psychologist with extensive experience in integrating behavioral health care across a variety of settings, including emergency medicine, inpatient, and primary care. He is currently a professor of emergency medicine, psychiatry, and quantitative health sciences at the University of Massachusetts Medical School. And now I would like to turn it over to Dr. Boudreau.
It's a pleasure to be with you today. I'm really looking forward to providing a brief overview of integrated behavioral health and primary care with a focus on depression screening and entertaining questions after the presentation. The questions we're going to answer today is briefly, what is integrated primary care? How are the levels of integration defined? And how does level of integration relate to screening for depression? And finally, how can we keep up to date in this rapidly evolving field? Following the presentation, you'll be prepared to determine the level of behavioral health integration present in a primary care practice, and you will know where to rapidly access the latest information related to integrated primary care with a particular focus on understanding depression screening in primary care. So the problems that we're facing with healthcare it goes way back to Descartes and the original mind-body duality. Descartes, of course, said that the mind is the seat of consciousness and is non-substantial, and the brain is the seat of intelligence and is substantial. And medical health care is provided in a similar way. Medical health care is often segregated and provided by medical doctors in medical settings, and psychological health care is provided by mental health providers in mental health settings. And these have been institutionalized as separate, as you can see in the image in the slide, where the American Psychological Association is separate from the American Psychiatric Association, and those are separate from the American Medical Association. So this duality exists in the way people are trained and in the way healthcare is provided. And it even extends to the health systems and insurances. Even the payers are segregated. So medical care is generally paid for by the primary insurance and psychological care often by carve-outs. The problem, of course, is that this mind-body duality is not really the way we live and we work or the way we see patients. So nearly half of all deaths are accounted for by a limited number of largely preventable behaviors. So the illness is really influenced by modifiable risk factors. And patients with mental illness are more likely to have medical problems and high-risk health behaviors like smoking. So when in practice, particularly in primary care practice, patients are often seen who have medical, behavioral, and mental health problems all rolled into one. This slide shows that within primary care, 52% of patients can be expected to have some kind of mental health disorder, which is roughly similar to the lifetime prevalence in the general community. So it's very common that a patient who is presenting for a medical problem has an underlying mental health disorder that's either affected by it or contributing to the medical problem. So what's the solution? The field of integrated care has been seeking to integrate both primary care in mental health and substance abuse in clinical practice so that the solution lies in providing care for the whole person and ensuring that the mental health and substance abuse issues are provided, are cared for in the same way and to the same extent or a similar extent as the medical problems are. This is a busy slide, I realize, but it's useful to help us to conceptualize the various levels of integrated care. This is a commonly accepted tool to help practices figure out exactly where they are in this continuum, with the lower levels of integration to the left at level 1 and the higher levels of integration to the right at level 6. You can access this same tool on the website provided below, and later in the presentation, I'll also provide the link for this in a larger fashion. But what you can do if you're trying to figure out where your practice currently stands is read through this table, and it describes how each of these levels are defined. So this is a nice overview of the levels of care. As you can see, starting all the way to the left, minimum collaboration is where the facilities are separate. So mental health and primary care are completely separate, and the communication is really driven by provider need and referrals, and there's very little integration or formal communication between the mental health provider and the primary care provider. All the way to the right, you see level 6, which is the highest level, or full collaboration, where the same space within the same facility is shared by medical and behavioral health providers, and they're often communicating with one another in a collaborative way. They have formal and informal meetings to support their care of individual patients, and it's really more of a culture of accepting that both behavioral health and medical health will be provided in the same location and by using a teamwork approach. And then you can look at all the different levels of collaboration between. I'm not going to go over each one right now because for time's sake, but they're pretty easy to review on your own. So let's turn our attention to some key points for depression screening. The current state of integration at a practice is likely to be associated with the acceptability of routine screening. Generally speaking, if there's low level of integration, in other words, there aren't behavioral health providers readily available who are not either on location or there's an established easy working relationship with, generally screening was likely to be less embraced. And that's because of what we have termed the Pandora's box effect. And so now that you know about it, you've screened for it and you've identified that the person is depressed, what do you do with it? And in lower level of integration, it's a little bit more difficult to answer this question than it is in a practice that has high integration. Regardless of integration, however, a structured clinical protocol is important to support screening. So you really would not want to push forward with screening unless a structured protocol that clearly defines what should happen and when it should happen is already established. So some key questions that you would want to answer in your protocol is who will be performing the screening, how will the screening be performed, where and when will it be performed, and what will happen if the person screens positive for depression. This would include, if an electronic health record is being used, making sure that the support for the depression screening and the actions necessary to address the positive screen are integrated into the electronic health record. So for example, the screeners, like the PHQ, should be integrated into the electronic health record. Best practice alerts and clinical decision support tools that are key to the screening should be available, and any patient resources such as information and psychoeducation on depression should be integrated into the electronic health record to make it easy to print relevant materials for the patient. So let's focus briefly on the lower level of integration. In a practice where there are no behavioral health providers available, the primary care clinician is often going to provide more of the first-line treatment. This is very common. So it is still important for that primary care provider to develop a strong mental health and substance abuse treatment referral list. So at a minimum, a list should be readily available to share with patients. And this should include information on local self-help resources, If there are depression groups, for example, or 12-step groups, many of the patients who are living with chronic depression also have alcohol-related problems, so 12-step groups can be useful for those patients. The resources are highly dependent on insurance, so when possible, the list should be organized according to insurance. And the practice should also consider providing referral and helplines where possible. Sometimes states or counties will have referral and helplines that help to sort through the nuances of matching a patient with a particular insurance to a provider. So in lower levels of integration, that kind of referral resource would be really important. In higher levels of integration, although some things may be easier, they still pose some significant challenges. So in a higher level of integration practice, the focus is going to be primarily on the efficiency of referring to behavioral health, on the communication pathways, clarifying roles and responsibilities, and identifying financial sustainability, which is a real challenge that integrated primary care has faced. Additionally, the mental health providers that are working in primary care need specialized training. Most mental health providers can't, if they have never practiced or received specialized training in primary care, simply be placed in a primary care practice and expected to work within an integrated care model. So training is in this role and in the culture and in the milieu of primary care is really important for the mental health provider. Most higher level of integrated care practices probably already have some experience with depression, particularly with treating patients who are presenting primarily with depression. So it may be a bit easier to protocolize screening since those practices may already have some experience with treating depression and with interacting with a behavioral health provider. I provided here an example of when I'm referring to a protocol. This is an example of a screening protocol that's in place at a site that actually uses a paper-based screening. So I'm not going to go through the whole chart here, but you can see it basically begins with the patient presenting to the registration desk, and they cycle through the care pathway all the way to the form that the patient completed, which is a paper-based form being scanned essentially and appended to the electronic health record. So this is an example of a paper-based protocol. Let's talk specifically about the depression screening. The most common screener that's been validated for use in primary care is the patient health questionnaire. There are two versions. There's the 2-item version, which is called the PHQ-2, and the 9-item version, which is the full version, the PHQ-9. The PHQ-2, of course, as you can see here in the diagram, is just the first 2 items of the PHQ-9, one assessing anhedonia, and the second assessing down or depressed mood. And a positive screen is greater than or equal to 3 on those 2 items. Generally speaking, what would happen after the PHQ-2, if the person is positive, is they would be administered the remaining 7 items for the PHQ-9, and then the totals scored, and the score compared to the criterion, which you can see here ranges from none or no depression all the way through severe depression. And in the slide, there's also proposed treatment actions. So there's some clinical decision support here that align with the severity of the depression. And more information can be provided, can be found in that link that's in the slide. So now let's turn our attention finally to how to keep up with integrated primary care resources. So I've compiled some high-yield resources here that keep up to date on the field of integrated primary care and provide a range of useful tools for understanding integrated primary care and understanding both the different levels, but also how to move from point A to point B to improve integration. So you can see here there's the Center for Integrated Health Services that is sponsored by SAMHSA, and their entire goal is to promote integrated primary care and other integrated behavioral health. There's an overview here on integrated care, the standard framework and levels of integration, which I showed to you before in a previous slide, can be available on this site. And there's an interactive flow sheet and a quick start guide for integrating behavioral health into primary care that helps to walk through key decision points and key steps towards improving behavioral health integration. AHRQ also has a considerable amount of information on integrated primary care. You see here there's the Integration Academy, which describes integrated primary care with some resources. There's a map of integration that shows various points across the country where known integrated primary care practices exist. There's a lexicon. That's a brief description of different definitions that are relevant to integrated primary care, and then there are some case studies that focus on the electronic health record. There's an excellent guidebook that's produced by the AHRQ Academy called the Guidebook for Professional Practices for Behavioral Health and Primary Care Integration. And the reason why I like this guidebook so much is that there are several case studies that are summarized, so it makes these abstract concepts very, very accessible in a concrete way. So in summary, an individual primary care practice may follow along a spectrum of integration from low to high, and this is likely to be an important factor in the practice's willingness to embrace depression screening. However, regardless of the level of integration, it's important to build a clinical practice protocol or pathway to standardize the particulars surrounding the screening and the handling of positive screens. And SAMHSA and AHRQ sponsor fantastic websites with detailed current information that make it easy to keep up with this evolving field. So you can access those sites and remain current and up to date. Thank you. That is all for our formal presentation, and I think we'll be opening this up for questions.
Yes, thank you for the wonderful presentation, Dr. Boudreau. And we are open for questions and answers. Dr. Boudreau, we do have one question that's come in. What do you think will be the biggest challenge in integrating depression scales into the practice?
I think the biggest challenge is probably deciding what format to use. Most of the time, if the PHQ-2 or 9 are going to be used, it's going to probably be used in a paper-based format because the questions are difficult to memorize, and the response options are not just yes or no. They're actually a Likert type of format. So if one wants to use the PHQ-2 or the PHQ-9, you have to figure out how you're going to administer it, and it was originally designed for paper administration. So this is probably the biggest challenge because if one puts it on paper, one also then has to build a pathway or protocols around administering the instrument, scoring the instrument, interpreting it, and then entering the results into the electronic health record. So it may turn out that actually this issue of when and where the screener is administered ends up being a relatively difficult challenge that influences the rest of the pathway, because if you can't administer it consistently, then it's going to be very difficult for the rest of the pathway to be engaged. So I think that's the biggest challenge. One big challenge is figuring out how you're going to administer it and when you're going to administer it. If a site has an electronic health record that supports electronic administration, which some electronic health records do, then there's still a little bit of a challenge with determining when it's going to be administered. For example, will it be administered prior to the appointment when the patient is at home and they are to engage in using the patient portal? So that would be a really nice workflow, because if the patient can be completed before they come in, then the results are there from the beginning of the treatment encounter. But that's sometimes difficult to do. Patient portal use is relatively limited in most places. So then the site might have to think about how they're going to administer the computerized screening once the person is shown for care. And usually that involves some kind of tablet PC or a kiosk in the waiting room where the patient can complete this screening before they see the care provider. So those challenges in how the screening is going to be administered and how it ends up getting into the electronic health record in a way that is efficient and consistent with current care pathways is probably the biggest initial challenge in actually implementing the screening that I think a site would likely face.
Thank you. Well, looks like we have another one. Do you think my team needs additional training to administer the PHQ-9?
Oh, that's a good question. The PHQ-9 is pretty easy to administer. As I mentioned before, it's usually done by self-report. So the biggest limitation is the format, as I mentioned, and literacy. So if a patient is able to complete the assessment on a piece of paper or by the electronic health record, or even by interview. Sometimes it is administered by interview, so it can be administered that way as long as the patient understands what the response options are. So there's not really a whole lot of training in administering the PHQ. The training comes into scoring and understanding what the risk levels are and what practices or actions should be taken in association with those risk levels. I showed a few slides earlier the commonly accepted thresholds and cutoffs. So those are very clearly defined, which makes it pretty easy to train people. And if it's built into the electronic health record or into some kind of job aid where people can very easily score and then figure out what the threshold is, it makes determining what the next steps are much easier. So I think the training would mostly be associated with how to score it, what the thresholds are, what actions should be taken based off of the threshold, and what the next steps should be in the protocol if the person is at one of those different thresholds. So it really is a blend of not only training people on how to use the PHQ-9, but training people on what the implication is for the care that the patient is supposed to receive.
Thank you for that very good description. We've received another question. How can I get my staff comfortable in administering the PHQ-9 once we have our process set?
I think that the biggest part of the comfort is actually having the process set. So most people, I think, are reluctant to do any kind of screening because they don't know quite what to do if the person is positive. And so this is the Pandora's box phenomenon, and that creates a psychological barrier to doing the screening. In fact, the U.S. Preventive Health Services Task Force has said that primary care practices should consider depression screening only if they have the wherewithal to handle the positive screens. If they don't and they don't know what to do or don't have resources to give to the patient, then they really shouldn't do universal screening. So that fear of what to do with a positive is a legitimate one, and if there's no easy answer, then people are not going to want to screen. So I think when a protocol is put in place and clear actions for the screens are identified, even if it's something, as I mentioned, in the lower integrated care practices, if it's as simple as having the discussion and then trying to make a referral and giving the patient resources for follow-up, then as long as it's clearly defined and the practice knows what to do with a positive, some of the resistance would decrease. That said, once the protocol is kind of built by the practice, it's really important to pilot it first, and that also helps with some of the reluctance. If you can pilot it with a small sample of patients or during a short time frame and do it in a way that allows the staff to express their concerns or for the team to identify problems with the protocols as they arise and then develop solutions for them, it makes it easier to get some traction because it's not all being done at once in a sort of a big bang approach. Instead, I would recommend taking small steps and piloting the process and tinkering with it and adjusting it until it feels comfortable for the staff.
Excellent advice. We have time for, I think, one more question. We've got a couple minutes left. As I integrate behavioral health assessments more into my practice, we may be functioning outside of traditional roles. What additional training would you recommend for me and my staff?
That's also a really good question. So it definitely requires some training to perform integrated behavioral health in an efficient way. So the mental health provider should really have experience or be experience of some formal training in how to work within a primary care practice. And the primary care physicians and the rest of the staff will also need to know how to interact with mental health clinicians that they may never have had as a resource. And the biggest education comes around understanding what the roles and responsibilities of those clinicians are at each site. So there's some generic training that is available, and you can actually access some training resources on the resource repository that has been curated, and I think we can provide a link for that. If you go under depression, and you'll see some subtopics under depression in that link, you'll look and find the training resources, and there's some specific training resources there that relate not only to integrated behavioral health in general, but also to integrating depression screening. So I think the training is going to be dependent upon the specific integrated care model that's put into place, the specific roles and responsibilities of the people in that model, and then going from there. Finding training resources online. There are online resources. There are also in-person training resources that are provided across the country.
Thank you, Dr. Boudreau. And now to turn it back over to our host, Stacey Hull.
Thank you, Dr. Boudreau, for such a valuable information. I know everyone found it to be very useful. I'd like to remind everyone that our next webinar will be held on May 18th. Dr. Paula Hartman-Stein will present on alcohol abuse in older adults. Thank you again, Dr. Boudreau, and thanks to all of you for joining us today. Remember, if we can be of assistance to you, please reach out. Enjoy the rest of your day.
Thank you, and that concludes our event.